Well, it's a real privilege to have local talent coming to this international conference. It's my pleasure to introduce Dr. Paul Macbeth. He has an interesting combination of being a surgeon at the same time that an adjunct professor of mechanical and manufacturing engineering. He's going to talk to us about the management of ventilators in the ICU. Thank you.
Good morning. Thank you for the introduction. Thank you to the committee for the opportunity to present on an interesting topic related to ventilating the difficult trauma patient. So the objectives of this presentation is to, first of all, review the basics of mechanical ventilation, and to review a few difficult ventilation scenarios that we commonly will see in trauma. In particular, I want to talk a little bit about persistent air leaks with chest tube management, cardiac contusions, ARDS, and traumatic brain injury. And I'll review some of the pathophysiology and management strategies in these cases. The positive pressure ventilation and the delivery of oxygen through mechanical ventilation is really the mainstay of ventilation techniques currently. And this graph here illustrates the respiratory cycle for a positively ventilated patient. The inhalation phase, you can see here the rise is dictated by the pressure and the airway resistance. Once it reaches the peak pressure, the plateau pressure during the hold period is dictated by the compliance of the lungs as well as the alveolar compliance during expiration. So compliance is really the distensibility of the system, and this is a physiologic term to describe the behavior of tissue. Someone who has a high compliance would have a very distensible lung, and an example of this would be someone with COPD. A low compliance is a non-distensible system, and these would be stiff lungs, and the example of this would be ARDS. The two most common modes of ventilation are volume-controlled ventilation as well as pressure-controlled ventilation, and then there's also more sophisticated combinations of the two. In volume-controlled ventilation, there's a specific volume that's delivered to the patient through positive pressure ventilation. The flow will remain constant during that delivery, and what changes is the pressure over the course of the respiratory cycle. And the pressure will fluctuate depending on the lung compliance. A poor lung compliance or someone with a stiff lung will have higher pressures as a result of a specific volume that's being delivered. A patient who's under pressure control ventilation will have a specific pressure target that's allowed. The peak flow will remain the same, however the flow will fluctuate depending on the lung compliance, and therefore the volume will change over the course of the respiratory cycle. This figure here is really to highlight the importance of the cardiopulmonary interactions. And this is important in the ICU when we look at patients who are being transitioned from spontaneously breathing to positive pressure ventilation. And the effects of positive pressure ventilation on both the preload of the heart and the afterload. So looking at the inspiratory phase of the cycle, of the breathing cycle, there's an increase in the pleural pressures, which will result in a decrease in the right ventricular preload and an increase in the right ventricular afterload, and the net result of this will be a decrease in the RV ejection. The transpulmonary pressure will increase with positive pressure ventilation, resulting in a decrease in the LV afterload, an increase in the LV preload, resulting in a net effect of an increased left ventricular ejection. During the expiratory phase, there's a decrease in the left ventricular preload, resulting in a decrease in the LV ejection. So this is a bit of a complicated slide, but what's important here is that we appreciate the effects of the hemodynamics on positive pressure ventilation, and this will come into play in an example that I'll give shortly. So I thought I would present you a case of a 56-year-old female who was a restrained driver. It was a prolonged extrication. The arrival time in the emergency department was delayed by several hours, and you can see the vital signs as presented here. This patient is physiologically deranged. The blood gas, the pH is 7.21, base deficit is -12, and the lactate is elevated at 7. Hemoglobin is 82, and there's also a troponin rise as well, suggesting a blunt cardiac contusion. Your workup involves a CT scan after resuscitation. Head and neck are fine. There are rib fractures on the left side with a flail segment. There's a left hemopneumothorax, a non-displaced sternal fracture, and a grade 3 splenic laceration and pelvic fracture. The patient's resuscitated, intubated, goes to interventional radiology for successful embolization of the pelvis, and undergoes a left tube thoracostomy. You're in the ICU and you're called to the bedside to assess this patient because of a persistent air leak. Persistent air leaks need to be evaluated at the bedside, and you want to determine if there's a mechanical leak from your system itself. So you want to evaluate all the connections to ensure that there's no abnormalities there. True bronchopleural fistulas in trauma are rare, but what's more common is the parenchymal pleural or alveolar pleural fistulas. And the way we can recognize this on a pressure volume or pressure flow diagrams are as illustrated here. And as you can see, these didn't turn out on the slides, but what you're looking for is a discongruency in the return volume from the ventilator. And so what we want to try and characterize are large leaks that are seen on mechanical ventilation. Our goal is to try and minimize the transpulmonary pressures or flow to allow sealing of that fistula to occur. And to achieve this, we minimize the end inspiratory plateau pressures as tolerated by the patient, and to minimize the chest tube suctioning necessary to keep the lung inflated. And the overall net effect of this is to minimize the transpulmonary pressures across that fistula. Next, I want to talk a little bit about blunt cardiac injuries. And these are important because the hemodynamic effects of a patient with significant blunt cardiac injuries can be quite severe and need to be appreciated, especially in a patient that's under positive pressure ventilation. The injury pattern that's most common is an injury to the right ventricle over the left ventricle. And what we often see is that is a concurrent pulmonary contusion, and with a pulmonary contusion, this will increase your right ventricular afterload. And with the increase in the right ventricular afterload combined with RV dysfunction, this may really precipitate cardiac failure. And so it's important that we ensure that in patients with RV dysfunction that they have adequate preload and afterload reduction. So evaluating the right ventricular preload is critical in terms of reviewing the patient's blood volume status as well as fluid loading. As we learned in the previous presentation, this is best assessed by transthoracic or transesophageal echo. Caution must be made when mechanically ventilating these patients, as the administration of positive pressure can have deleterious effects on the hemodynamics of a patient, especially in the context of a right ventricular injury. We need to consider also the afterload reduction in these patients with consideration of pulmonary vasodilatation. This can be achieved by decreasing the Pco2 by hyperventilating patients or by the use of phosphodiesterase 3 inhibitors. Next, I want to touch a little bit on acute respiratory distress syndrome. And in trauma, the incidence is about 86 per 100,000 person years, which represents about 7% of hospital admissions. And this is a clinical syndrome that has a mortality rate between 30 and 70%. Based on the Berlin definition of 2012, ARDS is defined as a new onset within 7 days of the known insult. Hypoxemia defined as a PF ratio of less than 200. Bilateral infiltrate seen either on chest X-ray or CT scan, and respiratory failure that is not due to a cardiac cause. The severity of ARDS is defined as mild, moderate, or severe, depending on the PF ratio, and the mortality is as shown here, with more severe cases of ARDS having a mortality rate as high as 45%. The pathophysiology is complex, etiology is wide-ranging, but primarily what we see in trauma is the acute phase characterized by pulmonary edema, diffuse alveolar damage, surfactant deficiencies, and inflammatory exudate. So how do we treat this? Well, we want to treat the underlying cause, which is resulting in the ARDS, and we want to provide supportive care. And supportive care is achieved through mechanical ventilation and the avoidance of further lung injury and restrictive fluid management strategy. We want to avoid what's called ventilator-induced lung injury, and this is characterized by volutrauma, atellect trauma, biotrauma, barotrauma, and oxygen toxicity. Volutrauma is the overdistension of the alveoli themselves. Atellect trauma is characterized by the repeated opening and closing of the alveoli, which causes shear stress and further injury to the airways themselves. This induces further biotrauma, which is mediated by inflammatory mediators, and the barotrauma is related to high pressures and lung-induced injury associated with that. This slide here essentially depicts our strategies for lung protective ventilation. So our goal here is really to provide a low tidal volume ventilation strategy targeting between 4 and 8 cc's per kilogram of tidal volumes. What we want to avoid is overdistension of the alveolar units and identify where to ventilate a patient in order to achieve this. Our plateau pressures should be targeted at less than 30 centimeters of water, and the allowance for permissive hypercapnia with the restrictive lung volume approach. This here is the ARDSNet protocol. It describes the use of different PEEPs at different FiO2 requirements and can be referred to when adjusting your PEEP in patients with ARDS. So in this first case that I presented to you, we've had some management conflicts. I've described to you the management of a pneumothorax with a persistent air leak, the blunt cardiac injury, which really you need to have a particular focus on the hemodynamics of a patient, and the management of ARDS. The challenge here is maintaining your ventilation goals in addition to your hemodynamic goals. The second case is a case of a 27-year-old male who fell while ice climbing. And this gentleman had a prolonged rescue as well. He arrived to the emergency department delayed after about 4 hours. He had a GCS of 6. His temperature was 33.2, and his vital signs are shown here. He was intubated in the emergency department, required high levels of oxygen to support his oxygenation, and he had dosimetry in his pupillary evaluation, and his CT scan demonstrated a traumatic brain injury with intraparenchymal hemorrhage. He had rib fractures and a pulmonary contusion. And so in this patient, we have a scenario where we have some conflicting management strategies and how to ventilate this patient. From a traumatic brain injury point of view, what really matters to the brain is to avoid hypoxemia. We want to protect the cerebral perfusion. And this is achieved by avoiding hypotension, to avoid high intracranial pressures and inadvertent hypocapnia. The cerebral perfusion pressure, as you recall, is the MAP minus the intracranial pressures. So the two parameters that we really want to pay attention to here is the Pco2. And with a decrease in this Pco2, what happens is you get constriction of the cerebral blood vessels, resulting in decreased ICP. The second parameter we want to pay attention to is the positive pressure, or the positive end expiratory pressure, which limits the amount of venous return to the thoracic cavity, causing intracranial venous outflow obstruction. So our goals here, our conflicting goals here, are targeted at each of these scenarios. So in the brain-directed strategy, we want to optimize our oxygen delivery, we want to control our PCO2, and we want to minimize the potential effects of PEEP. While in the lung protective strategy, we want to avoid overdistension of the alveolar units. We want to keep the lung open and ventilated, and we want to avoid cyclical collapses. This figure here represents the compliance curve of a patient with a traumatic brain injury. As I mentioned earlier, compliance is that ratio between the change in volume with change in pressure. The same effect of your lungs can be seen in the brain. So someone with a traumatic brain injury will have a stiff brain, and so their compliance will be low. So small changes in volume in that scenario will have dramatic changes in their overall intracranial pressures. So our Pco2 management in this scenario would be to maintain eucapnia, hypocapnia only in patients that have ICP emergencies. And in those patients where you do not have capabilities of monitoring ICP, you want to be cautious about having increased PCO2 levels in signs of low intracranial compliance. Features on CT scan that are worrisome are sulcal effacement of the basal cisterns, small ventricles, and hypocephalus. So looking at PEEP and ICP, this is a complex relationship looking at both pulmonary compliance, intracranial compliance, venous drainage, head elevation, and Starling resistors. For ARDS and brain injury, we want to start with what we know are best practices. So we want to target a low tidal volume ventilation strategy with low plateau pressures, monitor the PCO2 as well as ICP if allowed, and to provide careful consideration of improving CO2 clearance and minimizing intrathoracic pressures. And this can be done by decreasing the dead space within your ventilatory circuit, providing synchrony of ventilation, so these patients will often require sedation, and to drain any effusions or ascites. This figure here outlines an approach to ARDS in patients with TBI. So patients with suspected high ICP, you want to start with normal capnia, your low tidal volume ventilation of 6 cc's per kilogram, and limit your plateau pressures. If the respiratory acidosis is occurring where you're having a rising PCO2, you want to consider increasing your tidal volumes to still target a normal capnia and to follow your ICP values. And then consider alternative modes of ventilation, prioritizing CO2 elimination. So in summary, acute lung injury and ARDS are common in patients with TBI. They present a management challenge, particularly with relation to PCO2, and so it needs to be monitored carefully. PEEP appears to be safe in patients, though, who actually need it, and a lung protective ventilation strategy should prioritize PCO2 control and cerebral perfusion. Our rescue treatments are less conventional strategies. Inhaled nitric oxide, this is for patients that will give you an increase in the pulmonary or a pulmonary vasodilatory effect. So patients with pulmonary hypertension. Prone positioning, which is often a challenge in patients, in traumatically injured patients. Partial liquid lung ventilation and extracorporeal oxygenation. Thank you.